In the last video, I explained the exact neurological sequence behind PMS. The progesterone crash, the GABA drop, the serotonin suppression, and I said I would tell you where the clinical line is between PMS and PMDD. This is that video. I need to be direct with you about something before I explain the diagnosis. PMDD, premenstrual dysphoric disorder, is real, it is measurable, it is in the DSM-5, and it is significantly underdiagnosed. Most women who have it have already been told they have depression or anxiety or that they are simply more sensitive than other women. They have not been told that their brain responds differently to a normal hormonal fluctuation, which is the actual clinical picture. If what I described in the PMS video sounded familiar but significantly more extreme, if it affects your ability to work, your relationships, your sense of who you are, this video is for you. Hi, I am Dr. Sunaina, practicing gynecologist. Let us go through this properly. PMDD is a diagnosable condition. It has formal diagnostic criteria in the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders. Here is what those criteria actually require. First, there must be at least 5 symptoms present in the week before your period. And of those 5, at least one must come from this group of 4. Marked mood swings, marked irritability or anger, marked depressed mood, or marked anxiety and tension. The word marked matters here. Not mild, not manageable with effort. Marked, meaning significantly beyond your baseline. The remaining symptoms, which can make up the rest of the 5, include decreased interest in usual activities, difficulty concentrating, lethargy or low energy, appetite changes or cravings, sleep disturbance, a feeling of being overwhelmed or out of control, and physical symptoms like bloating, breast tenderness, joint pains. 2 additional requirements are critical. These symptoms must begin in the luteal phase and resolve within a few days of your period starting. And this pattern must be present in most cycles over the past year, not one bad month. A consistent, cyclical, repeating pattern. Here is the question most women ask at this point. If PMS and PMDD share the same hormonal trigger, what makes them different? The answer is not the hormones. Research has consistently shown that women with PMDD do not have abnormal hormone levels. Progesterone crashes at the same rate as in women with PMS. Estrogen dips the same way. The difference is in how the brain responds to that normal fluctuation. In the PMS brain, GABA receptor sensitivity is standard. The progesterone crash causes a reduction in GABA function, which produces moderate emotional dysregulation. In the PMDD brain, GABA receptor sensitivity is altered. The same hormonal fluctuation, identical levels of the same hormones, produces a significantly more severe neurological response. There is a specific compound involved here called allopregnanolone, a metabolite of progesterone that normally has a calming effect on GABA receptors. In women with PMDD, this compound appears to have a paradoxical effect, activating anxiety rather than reducing it. This is why PMDD is classified as a disorder of neurological sensitivity to normal hormonal change, not a hormonal disorder and not a mental health disorder in the conventional sense. Same hormones, different brain. I want to tell you what functional impairment actually means in a clinical context, because this is the threshold that separates PMS from PMDD, and most women do not know it exists. PMS is disruptive. PMDD is disabling. The difference is measurable. In PMDD, the luteal phase symptoms are severe enough to affect your capacity to function at work, in relationships, in your ability to manage basic daily life. I am not describing a difficult few days. I am describing a pattern where, for a predictable window, every cycle, a woman is a significantly different version of herself, where she withdraws from relationships because she cannot regulate her responses, where she cannot meet professional obligations, where she describes the experience as losing herself, not feeling low, not feeling irritable, but feeling like a fundamentally different person who she does not recognize. That clinical picture has a name and a diagnostic framework. What happens instead, repeatedly, is this. A woman presents to a doctor with depression and anxiety. A mood disorder is diagnosed. Antidepressants are prescribed. And no one asks, does this pattern follow your cycle? Does it resolve when your period starts? Because if the answer to both of these questions is yes, that is not a primary mood disorder. That is a hormonal pattern producing neurological consequences. And those two things are treated differently. I have to say this clearly. Antidepressants are not the wrong treatment for PMDD. SSRIs used specifically in the luteal phase have a strong evidence base for PMDD. But prescribing a full-time antidepressant for a condition that only presents for 10 days a month without ever investigating the hormonal picture is not the same thing. The diagnosis matters. The mechanism matters. If you are watching this and recognizing your own pattern, here is what to do with that recognition. Track 3 cycles. Every day from approximately day 15, note the following: your mood, your anxiety level, your energy, your sleep, your capacity to function in your normal responsibilities, and specifically the day your symptoms begin and the day they resolve. What you are documenting is a pattern across time. One bad month is not PMDD. A consistent cyclical pattern, symptoms appearing in the luteal phase, severe enough to affect function, resolving at period onset, repeating. That is the clinical picture. When you go to your gynecologist, do not say, I feel terrible before my period. Say this: I have tracked 3 cycles. My symptoms begin consistently around day 22 to 24. They include, and then name them specifically using the DSM-5 list I showed you. They are severe enough to affect my work and my relationships. They resolve within 2 days of my period starting. I would like to discuss whether this pattern warrants a PMDD assessment and what investigation and treatment options are appropriate for me. That is a clinical presentation. That is data a doctor cannot dismiss. Bring your tracking record. The difference between I struggle before my period and I have 3 cycles of documented luteal phase function impairment is the difference between living with nothing and living with a plan. PMS and PMDD are not on a spectrum of severity where one simply becomes the other if it gets bad enough. They are neurologically distinct. Same hormonal trigger, different brain response, different functional impact, and different treatment approach. If your luteal phase symptoms are disrupting your life every single cycle, that is worth investigating. You are not too sensitive. You are not dramatic. You have a cyclical, measurable, treatable pattern. In the next video, I will be covering PCOS, specifically the androgen-anxiety connection that most PCOS conversations never reach. Subscribe so you do not miss it. And if today's video helped you put language to something you have been experiencing, that is what this channel exists to do.